Welcome everybody to this second alumni online seminar of this year that we will have a very nice presentation about humanitarian wash with two excellent speakers. First, that I will introduce them, but first let me remind you to please be muted so that it's better to hear all the speakers. And whenever you would like to have a question, write it in the chat that after the presentation of both speakers, we are going to read the questions and they will address your questions. But let me introduce first to our speakers. With me today is Ms. Tineke Hooijmans, that she is Associate Professor of Sanitary Engineer in the Chair Group of Sanitary Engineer of the Environmental Engineer and Water Technology Department at IHE Delft. And her research interest is in the field of nutrient removal and modeling of wastewater treatment processes and systems. In the course of the years, her research area has been expanded with the sanitation solutions for the urban poor, emergency sanitation, fecal sludge treatment. She coordinates the yearly Humanitarian Wash Graduate Professional Diploma Program offered by IHE Delft in collaboration with UNICEF as lead of the Global Wash Cluster, developed in cooperation with a broader humanitarian sector. Tineke has more than 60 publications in peer-reviewed journals. She has supervised many MSc and PhD candidates, and she is responsible for overall execution of the Urban Water Sanitation Program as coordinator. Furthermore, she has worked in capacity building and research projects abroad and has been project leader in several of them. Our other guest speaker is a student at the moment and an alumnus in a few months, and is Feranmi Folahan that comes from Nigeria and is completing the MSc program at IHE Delft. He is a medical and public health microbiologist with experience in microbiological research and academia. His work focused on infectious diseases and environmental health, particularly among preschool and school-age children in rural communities across western and north-central Nigeria. Over the years, he has conducted research on neglected tropical diseases with significant contribution to understand Schistosoma spp and other soil-transmitted health myths. His work has explored prevalence, disease ecology, transmission patterns, and health impacts among vulnerable populations, providing evidence-based data that support informed and target intervention strategies in underserved communities. He is currently conducting research under the RISWASH project on the exposure risk of fecal-oral pathogens across multiple environmental pathways in humanitarian settings, whereas access to adequate wash is limited. The aim of his research is to identify fecal contamination in various environmental matrices and determine the dominant transmission routes. Ultimately, the goal is to produce knowledge that supports timely, target, and efficient interventions in preventing diseases outbreaks in vulnerable populations. And with further ado, I would like to pass the mic to our first speaker, Ms. Tineke Hooijmans.
Thank you very much, Maria Laura, for this nice introduction. And thank you very much for inviting us to give a presentation in the context of the Risk Wash project. So here you can see the title of my presentation. So it is a risk-based approach to humanitarian decision making. It's in humanitarian wash context, and it is a project that is funded by the IHE Delft Water and Development Partnership Program. My presentation, like Maria Laura mentioned, will be followed by a presentation by Feranmi, who will narrow down on his research, and I will more sketch the context and the development of the program and what we are actually studying. So the reason for the development of this project is the following. In humanitarian settings, people are more prone of contracting fecal-oral diseases such as cholera. And this is a major concern, especially in a camp setting, where the conditions are suitable for rapid spread of diseases. The primary barrier for the transmission of the fecal-oral diseases is sanitation. So this is the focus of our project. And there is a need to tailor public health approaches and interventions in humanitarian context because there is always limited funding, so choices have to be made. And data and tools are required to aid the decision-making process. And this all led to development of the Risk Wars project. And like I mentioned in this presentation, we'll show the conceptual approach taken. But first on the context of the project. So we're working in a humanitarian setting, and we have selected 2 camps, one in Bangladesh, Cox's Bazar, and one in Uganda, Imvepi. And you can see here 2 pictures, one of Bangladesh, Cox's Bazar, and here one of Imvepi. And as you can see, the contexts are already quite different. So the density is extremely high in Bangladesh camp. There, what we have done is we have selected 6 different fecal sludge treatment plant catchment areas. There we focus on. And we work together with academic, research, humanitarian and governmental organizations. And in the project, we have 3 PhD students, one with ICDDRB, that is the Institute for National and International Institute for Public Health in Bangladesh in Dhaka, one at the Makerere School of Public Health in Uganda, and one at IHE. And we also have one PhD student, which is also related to the project, but not an official part of the project, because he's doing his research parallel, and that is a PhD student from UNC in the United States. And we foresee 18 MSc students working on the project, of which Feranmi is one of them. The duration of the project is 4 years, so we started in the end of 2022, and we will continue till the end of 2026. So we'll use and further develop available risk-based sanitation assessment tools, which will all be implemented together with the humanitarian and the refugee communities. So, like I mentioned, the approach of the project is risk-based, and the idea is that we further develop a participatory SANIPath approach to quantify the health risks related to fecal contamination. E. coli is the indicator organism in the public and the private domains for different transmission pathways and for different groups, including the vulnerable groups. And here on the slide, you can see also some pictures taken about the SANIPath process and also the outcomes. So it's a qualitative assessment process. The next, what we do is also we will assess the occupational health risk profiles across the sanitation value chain through a participatory sanitation safety planning approach, which is a semi-quantitative risk assessment approach. And here you can also see some pictures taken. So we focus on the sanitation value chain. So people working at the sanitation value chain. You see here all the steps that we have to take. And here you can see the development of a risk matrix, which is already giving values to the different risks, resulting in a risk score and a risk level. Well, to continue, what we also will do is evaluate the performance of the different FSDPs. So there are a lot of FSDPs trialed in these camp settings because the humanitarian sector realized that they have to treat also the fecal sludge that is produced. Containment is not sufficient. So there are a lot of different systems. And the question is, which one is, well, let's say the best, or are they all performing similar in relation to chemical removal efficiency, but also in relation to pathogen removal efficiency. And here we use the so-called Techman array cards, in which we can target different pathogens. We're also focusing on and examining the environmental risks posed by the discharges from the fecal sludge treatment plants. So what is the effect of the discharges on the surrounding environment in the camps? And it is through an environmental risk assessment method. And finally, there is also a quantitative microbial risk assessment in which we quantify risk from specific pathogens. And this is all work that also Feranmi will focus on more in his presentation. So the main outputs are of the project and this initiative to have a risk assessment in the public and private domain, to have a risk assessment across the sanitation value chain, including fecal sludge treatment plants, to have a risk assessment for the environment of the discharges of the fecal sludge treatment plant, and also to have a risk assessment of the probability of the fecal-oral diseases in the population. So we work on the two different case study locations for each of the approaches. We will use and we will adapt the existing tools, which will result in a combined risk map for each location. And we'll also evaluate the performances of the fecal sludge treatment plants. What is very important of such a project is that we don't do it just for the sake of science and education of PhD and MSc student, which is of course important, but also we will develop and are developing training materials on the tools. So on the SANI path, sanitation safety planning, QMRA, also the environmental risk assessment, which will be trialed and further developed for the humanitarian sector and water sector professionals. We will also develop protocols for participatory research, for sampling and analysis. And we will share the health impact framework to support decision making in the humanitarian context. So the content will all be open source and shared beyond the partners via the IHE Delft repository, via the Humanitarian Sanitation Hub, via webinars, via blogs. And we're also giving workshops on the tools in Uganda and Bangladesh for professionals working in the humanitarian sector. And here you can see a picture of a workshop that we held in Cox's Bazar. And here also on the right, you'll see a thesis of one of our MSc students who worked on the occupational risk associated with emptying and transport of fecal sludge in a humanitarian setting. Now, this is my last slide because I also want to acknowledge the partners that we are working with. So like I mentioned, we work with ICDDRB in Bangladesh. We work with Makerere School of Public Health in Uganda, with BRAC, a very large international NGO in Bangladesh, with Trent in Ghana on the sanitation safety planning, with the Uganda Red Cross Society, the Netherlands Red Cross Society, UNC, and also with some governmental organization. And finally, with the technical working group on fecal sludge management, which has now been transformed into the Humanitarian Sanitation Hub. So this was my last slide. Thank you very much for your attention. And I would like to give the floor to Feranmi.
Thank you very much. Now we share my screen. Thank you so much for having me here today. I'll be presenting our research on the microbial risk assessment of exposure pathways to Faecal-Oral pathogens within the Rohingya refugee camps of Cox's Bazar in Bangladesh. Just a little background on Faecal-Oral pathogens. These are microorganisms that are found in feces, and as the name implies, moves from the feces to the mouth through various routes, either directly or indirectly. And it is important to note that poor sanitation and hygiene are the major influencers that promotes the transmission of these pathogens, and they have significant global implications. For example, about 2 billion diarrhea cases are reported annually caused by fecal-oral pathogens, and more than 61 million disability-adjusted life years are attributed to fecal-oral pathogens. That's the measure of the burden of disease caused by these pathogens. And strikingly, children in the low and middle income countries are mostly affected by these pathogens. So this gives an understanding of the gravity of implications that these pathogens have to public health. The pathogens are transmitted specifically by the combination of three major components: the host, the pathogen, and the environment. An infected host will discharge this pathogen in the environment that serves as an incubator or a vehicle through which it is transmitted to a new susceptible host. And this can happen in various through various routes, which have been described using the the F diagram, which includes various pathways for the transmission of fecal-oral pathogens. And this could be by fluids, which might be drinking water or surface water, the fingers, which has direct contact with fecal pathogens. It could be flies that serves as carriers of the pathogens from feces to food or to mouth directly, and then from fields or soils where children or farmers can come into contact with fecal pathogens. So these pathogens can be transmitted through these various pathways within the environment. And it is worthy to note that sanitation, like Professor Tineke said earlier on, together with hygiene, are the primary barriers to preventing the transmission of fecal-oral pathogens. Safely managed sanitation will prevent contact, will keep feces from getting in contact with humans, while if peradventure there is contact, a good hygiene would prevent the transfer of these pathogens to the mouth. So both are very important in preventing the transmission of these pathogens. And why are refugee camps important in respect to fecal-oral pathogens? The increasing level of conflicts and natural disasters due to climate change and other factors has increased the number of forcibly displaced persons globally. And a large chunk of these people ends up in the refugee camps. This increases the population density in the refugee camps, and high level of population puts pressure on the sanitary and sanitation infrastructures provided within the refugee camps. Also, refugee camps are initially built as temporary settlements for displaced persons, but these are beginning to change as continuous conflicts and natural disasters keeps refugees within the refugee camps for longer than expected. And when they continue to have this level of permanent residence within refugee camps, there is a problem of pressure upon available resources. And this can increase the risk of exposure to fecal-oral pathogens. And also, the limited funding and resources within the refugee camps also makes it a key context for observance of fecal-oral pathogens. And that is where the Risk Watch project comes in, like earlier discussed by Professor Tineke. The project focuses on assessing the risk of fecal-oral pathogens within humanitarian context. And the project aims to develop risk-based decision-making um, um, tools for making decisions that are targeted towards intervention and the prevention of the transmission of these pathogens. It would be nice if we follow up with this project on our LinkedIn page to see what we do and also to get updates on our research from our LinkedIn page. This research basically has objectives that focus on quantifying the fecal contamination within multiple environmental matrices, and also to assess indicator levels within these pathways, and also to identify the relationship of those indicator levels with pathogens that are detected in these pathways. And also the research is to evaluate behavioral practices of refugees within the refugee camps, and also to relate these practices to environmental pathways. And finally, the research is to estimate the burden of disease from exposure to fecal pathogens using the quantitative microbial risk assessment tool. For the sake of this seminar, I will be presenting on the first two objectives. And like I said earlier on, you can follow up on the LinkedIn page to see updates of this research and other researches that is conducted under the Risk Wash project. The Rohingya refugee camp is made up of various sub-camps. As of 2025, there are 33 sub-camps in the Rohingya refugee camp. And of these sub-camps, my research focuses on Camp 18, one of the camps, and specifically on the fecal sludge treatment plant catchment area within the Camp 18. And this catchment area is made up of about 6,300 individuals, a large percentage of which are children. More than half of the sanitation infrastructures in this camp are emptied and transported manually, which do not only expose the workers to risk of infection through fecal-oral pathogens, but also could result into environmental contamination as well. And this is a snapshot of the refugee camps. Here we have children who are playing on the football ground with open drains very close by to the playground. Most times these children sit on these um, drains and sometimes maybe step inside. Whereas there are some drains also very close to households within the camps. These are shallow drains that oftentimes contains fecal pathogens. And also in the middle picture below, you can see the playing ground also very close to an open drain as well, where sometimes the football often goes into the drain and these children picks it up with their bare hands. And this shows the typical example of the camp and how it's exposed to risk of transmission of fecal-oral pathogens. This study, this research, adopted the SANIPATH standard procedure for environmental sampling and analysis, which was developed by Emory University in the United States. And we focus on 7 environmental pathways for this research. And 5 grab samples are collected per pathway. And for analysis, we concentrated on pathogens that are reported as being prevalent in Bangladesh. And also, we selected our pathogens based on the status of their of them being notifiable. For example, these are pathogens that upon outbreak or upon detection, it is mandated by law to report the presence of this pathogen. So we focus on these pathogens of interest to identify these pathogens within the context of Camp 18 in Cox's Bazar. Having carried out the analysis from this samples collected, we looked at various analyses. For example, we conducted E. coli analysis and also molecular analysis, which included DNA extraction and qPCR. For the E. coli analysis that we carried out, the drinking water samples had no E. coli. It didn't bring forth any level of E. coli contamination. However, the soil samples and the drain water samples had consistent contamination. All samples were contaminated with E. coli, and the drain water samples had the highest level of contamination, ranging from about 620,000 E. coli CFU per 100 mils. The toilet swabs, interestingly, had no contamination, which oftentimes people, the knowledge is probably toilet samples, swab samples will most often have contamination, but then we will understand factors that could be responsible for this as we move on. The surface water samples also show some variable level of variability in contamination, with some not contaminated, while others are as high as 12,000 plus CFU per 100 mils. The street food also show different levels of contamination, but it is confirmed in this study that some of the street foods within the camp are contaminated, as well as raw produce as well. In comparison with other studies, looking at the Sanipat studies, and also general studies within the low and middle income countries, the level of contamination in this study, which will be expected to be higher than other contexts, because this is humanitarian context, and it is expected that there should be an high level of contamination within humanitarian context compared to urban settings. However, we've come to observe that the level of E. coli contamination within the context of the humanitarian settings is most times lower or similar to what is entailed in urban settings. And this opens our eyes to understanding the idea between the level of sanitation systems within the humanitarian settings compared to what is given within the urban settings, or the um, the general context of urban levels. And if we look at the different pathways that we examined within this study, drinking water samples that ordinarily um, would not have contamination in the humanitarian settings. Some of other settings also reported low level of contamination, which is similar to what we observed in our studies. For example, the drain water samples in our study had higher level of E. coli contamination, and it's the same with what is reported both in the Sanipat studies, which specifically used the Sanipat procedure that we also used in this study, and also in other general urban settings in the low and middle income countries. And finally, under this E. coli contamination results, the dominant exposure pathways for the Sanipat studies was the raw produce. The raw produce was identified as the dominant exposure pathways. However, this varies in our own study, because the level of contamination in our studies is more or less, it's lower compared to what was reported in the Sanipat studies, as well as in the general urban settings. This gives more questions and more understanding into the level of contamination in humanitarian settings compared to the urban settings. And it is important to note that there is no studies that has looked at environmental contamination within the humanitarian context, as all other studies, including the Sanipat studies and the general urban studies, has been focused on urban context. This is practically the first study that will be looking at the contamination level within humanitarian context. And this opens our eyes to understanding what the comparison between humanitarian settings are compared to that of the urban settings. For the qPCR analysis that we conducted, it gives the results that we observed shows level of contamination for Faecal-Oral pathogen contamination in drinking water, in soil samples, in drain samples, in the street foods, and also in raw produce. Interestingly, we have the highest level of contamination in our drain samples, which in urban settings in the low and middle income countries, it is often reported that drain water samples also have similar level of contamination with domestic sewage. And our results also agrees to what has been in literature, which is also reported in other urban settings. However, in comparison with other contexts, we saw that higher level of contamination with Vibrio cholerae and norovirus from our samples also agrees with what has been reported in lower and middle income countries. The Vibrio cholerae and norovirus are the most contaminated pathogens within the context of Camp 18, where our study was conducted. We detected the presence of Shigella and Ascaris, but quite very low when compared to reports from urban settings as well. But the most striking thing from this study is the comparison of the E. coli levels with the detection of fecal-oral pathogens. In drinking water samples, we discovered no E. coli contamination. However, this same pathway, the drinking water, was positive for Vibrio cholerae and for noroviruses. The same thing goes with some other samples like the surface water sample and also the raw produce that showed no E. coli growth. However, Vibrio cholerae and norovirus, as well as other pathogens, were observed in these samples. And this brings up it opens the eyes on the idea of E. coli as an indicator for fecal-oral contamination. Although more research needs to be done in this aspect, but this is more or less like a snapshot to understand that E. coli contamination cannot oftentimes translate into the presentation of fecal contamination, particularly looking at the humanitarian context level. Now let me move on to the preliminary observations from this study. Fecal contamination with E. coli has been established as a recurrent fact within the humanitarian context. The environment is contaminated with both E. coli and key pathogens like Vibrio cholerae, Shigella, noroviruses, and Ascaris. And also it is evident that the drain water samples actually represent a critical exposure pathway because of the high level of contamination levels for both E. coli and the pathogens that were detected using the qPCR. The E. coli testing alone, like I mentioned earlier on, might not be adequate for assessing drinking water safety, as we have seen that drinking water with no E. coli contamination or E. coli growth also, has shown fecal contamination within the context of the camp. Also, street foods and raw produce pose direct infection risks of fecal-oral pathogens within this context as well, because fecal pathogens have also been detected in these samples. Also, soil contamination with E. coli and Vibrio cholerae is a significant health risk for children. Earlier on, I showed the pictures of the context of the camp where children are very close and playing on the soil. It's a level of risk for children who often spend most of their time playing on the soil which are contaminated with these pathogens. And finally, the surface water contamination levels in this study also opens our eyes to the potential risk of exposure, as most of this surface water in the context of the camp are used for agricultural produce and processes. Many of them are used for irrigation, like wetting of crops and mostly vegetables, where they are confined and used for this purpose specifically. And also, to some extent, this surface water are also taken for medicinal purposes and are taken as fluids to be drink in order to carry out some traditional practices. So these are factors that we've seen within the context of the refugee camps in Cox's Bazar that predisposes the refugees or the context of the people, the population, to the risk of fecal-oral pathogens. And as a wrap-up, the next step for this research would be, one, to consolidate the pathogen data that has been gathered. The next step will involve quantifying and standardizing our results into quantitative data that can be used in the QMRA tool, and also integrating the exposure assessment from the camp as well within the dose response model within the QMRA tool for a robust analysis to estimate the burden of disease associated with each of these exposure pathways that have been identified in this study. And for recommendations, it is important that we expand this study and to look at the level of E. coli to pathogen ratios, because it is obvious from the snapshot that we have in this study that some pathways, E. coli levels cannot be used to predict the presence of fecal-oral pathogens. Also, it is also important that molecular source tracking is carried out to identify and differentiate the sources of fecal contamination in each of these environmental pathways in this context. And also a farm to fork risk modeling is important to trace the transmission of fecal pathogens from the source down to the level of consumption within this context in order to enhance targeted and effective wash interventions for humanitarian context. And this shows the process of our analysis in this study. From the pathogen detection and quantification, then we'll move on to the concentration of the samples by converting our gene copies of the pathogens detected in each of the samples for the quantitative data that we need in the QMRA model. Then we incorporate the exposure assessment as well as the dose response modeling. And then this will be, the QMRA tool will be used to estimate the burden of disease in DALIs, and this will give us the level of, will help us to identify the dominant exposure pathways within the context of the humanitarian settings where this study was carried out. I would also like to acknowledge the sponsors and the partners of this study, IHE Delft, ICCDRB, the Risk Watch Project, BRAC, and also the BDRC, RCS, and also the IFRC. Thank you very much. And please let me know your questions.
Thank you very much, Tineke and Feranmi, for your great presentation, and all the best, Feranmi, for your MSc. And we will open the floor for the questions, and we have the first one from Ricardo Silveira Bernardes that requests where he can access the word publication, and you can find in the chat the link that Tineke has posted. And the first question is from Supido Joseph, and he asks, we have over the years concluded that the E. coli is an indicator for fecal contamination. Kindly explain any doubts on this assertion as you flag. I'm in the humanitarian sector, and this is the principal indicator that we use to check on water quality. Is this the principal indicator that we use to check on water quality?
Okay. In response to that, the WHO has advised E. coli to be used as indicator for fecal contamination, and that is widely accepted. The question now comes, how acceptable has been this is the use of E. coli as an indicator? There are major studies, different studies that have also from literature that have also established that for some certain pathogens, E. coli is insufficient. For example, for viruses, E. coli is insufficient as an indicator for viruses, and that is why the somatic coliphage has been advised, and some other viruses have been advised as an indicator for viruses. If E. coli is oftentimes not established, if it has limitation as an indicator for viruses, there could also be some level of limitation based on various factors like survival rate in the environment, source of contamination, and various things could also affect the reliability of E. coli as an indicator for fecal contamination. And that is why in this study we are looking at that It is not a fact right now. It is part of our process. So we are looking at how reliable is E. coli. Yes, it is widely accepted because that is the standard. But how reliable will this be in the long run for various pathogens, looking at various factors of climatic change that we are having at the moment and some other factors that come to play. And that is why in this research, in the Risk Watch project, we are looking at what could be the aftermath of E. coli being reliable or not being reliable as an indicator for fecal-oral pathogens. So at the moment, we have not produced any facts. It's still an ongoing research, but the question keeps coming up, how reliable is E. coli as an indicator for a broad range of fecal-oral pathogens?
Thank you very much, Franny. I don't see any more questions. Would you like any one of you to add some thoughts that had come to the presentations? Please take the floor. Don't worry. Please, there's a question coming for Mohamed Dan Hassan, and she asks, please, what are the effective methods of treatment of the water affected by E. coli contamination, coronavirus?
Okay, maybe I can take the floor, Feranmi.
Okay.
Here, yeah. So maybe Feranmi, you can add some things to support. But I think that it's one of the objectives of the Risk Wash project to compare also the different treatment plans that are currently working in the context of humanitarian settings, in how far they are removing indeed E. coli or other or viruses or helminth eggs. So that is an ongoing study and we have no conclusions yet, but we are going to compare the different treatment plans on the removal of pathogens. And those treatment plans are different in operation. Some are aerobic, some are anaerobic. We have wetland systems. We have systems with sand filtration. So we just have also to look and see what are the differences in relation to those different treatment plans in removal efficiency.
Thank you, Tineke. I think that you have answered the question because Ricardo Silveira asked, in your opinion, which indicator can be in place of the E. coli virus? I don't know if you want to add something.
Yeah, I think it's not in place of. I think E. coli remains
Is
still, a significant indicator because of there are good reasons why the WHO has selected for E. coli, also because it's relatively easy and quick to analyze and get the results. But like Feranmi mentioned, there are also when you do this and only focusing on E. coli, you might oversee indeed or forget about other pathogens that might still be present and not detected in relation to E. coli, like the viruses or other pathogens. So it is not that you have to replace it, but maybe we need some additional analysis to get a good picture and understanding of the health risks.
Thank you very much. And we have a question of Bhuvaneshwari Shanmugam that the question is the sampling conducted over different seasons, looking at the seasonal change and how it affects disease transmission?
Okay, thank you very much. The sampling was not conducted over different seasons. Um, Part of our literature analysis prior to the to the sampling period of this research, we looked at what has been reported within the context of the Cox's Bazar refugee camps, and based on that, we looked at the season or the period that pathogens are most likely to be detectable, and we focused on that. Although it's also one of the limitations of the study because we could not expand through various seasons. But at this period, we looked at the dry winter seasons, which has been established as the period for survival of pathogens in the environment, particularly viruses. They thrive and survive more at this period than during the rainy season or the wet seasons, where other contaminants could affect environmental contamination. For example, during rainy season, floods could contaminate environmental pathways which are not originally contaminated by fecal exposure within the context of that camp. So we looked at the most feasible period that will give us a representation of contamination within the context of the camp and the environment at the time of our studies. So that was basically what we focused on. Thank you.
Thank you very much. And we have another question of Juan Savioli. I think, no, sorry. Um, sorry. Another question for Professor Gopal Kumar from India, who thanks Tineke and Feranmi and for the very informative presentation. And he would like to ask how scalable is the risk wash approach for use in other refugee emergency contexts? Thank you.
Okay, thank you for that question. No, it's definitely applicable to be used in other refugee and emergency contexts, and that's also why we are updating the humanitarian sector, and we have everything as open source material. We're also giving trainings on the methods, on the different techniques. So we really hope that others, can make use of the approaches that we are advocating here in this project.
Thank you very much. And I don't see any extra questions. So I would like to invite Ferrani and Tineke to say the last words to conclude this event and to thank you, the speakers, of course, for this fantastic presentation, to remind you that you will receive the recording video of the presentation that you can share with colleagues or persons that can be interested in the topic at your convenience. And you will receive it in the coming days. And also I will put the link that you can find other online seminars. And last but not least, the next online seminar will be at the end of this month, and we are going to focus on artificial intelligence. So it could be also very interesting. You will receive information soon. But thank you very much to all of you. And I would like to close just passing the floor to Ferrani and Tineke for the last words.
Okay, thank you very much, Maria Laura, and thank you all people present, and thank you very much for your questions. It was great to have you here. And also Feranmi, thank you very much for your nice presentation, and success with the last parts of it.
Yeah. Thank you so much.
Thank you very much, and all the best, Ferrani, for your presentation.
Thank you,
and
Maria.
For the presentation to come for your MSc.
Thank you
very much, and see you all maybe in another online seminar of this year. Thank you very much.
Bye.